very excited about this next, I'm not going to call it a presentation, it's a panel. We're going to run it as a panel. You, the room, are going to meet our VCRC VF fellows that we've had over the last year or two. And they can go ahead and start. Oh, they're going to I'm going to parade them across the stage here. All right, so who wants to go first? We'll say Dr. Jessica Bloom. She's actually a pediatric rheumatologist with a specialization in vasculitis, and she's at Children's Hospital of Colorado. Give her a warm welcome. She was on the winning team of Family Feud last night. And then we have, let's see, who wants to go next? We have Marta Moura at the Mayo Clinic. We have Dr. Kinanah Yaseen from the Cleveland Clinic. And then we have Dr. Divi Cornec from Brest University in France. And he looks French today, right? He's like, good on mine. And he will forever be in the minds of us as the man who came up with emu last night during Family Feud after missing France as a country that spoke French. So I'm going to run this as, like I said, as a panel, kind of informally. I mean, we have Ed working the Q&A for us, so if you have questions, you know, fire them in. But that being said, I think with the time allotted, I'm going to control it a little bit, and they're probably going to answer some of the questions you have. I guess let me start by just giving my story a little bit, and because I was a VCRC fellow 5 or 6 years ago, and it was incredibly helpful in my career and to give me the confidence to take care of the complex patients that are in this room and not in this room. And so for that reason, I'm very thankful to the VF and to the VCRC and to the two institutions, Vanderbilt and the Cleveland Clinic, because that's really the partnership that has to occur to get this done. Is you have to have somewhere to land, somewhere to train you, and then the funding that is the VF. And that all came together for me, and it's starting to come together for these folks as well, okay? So I'm gonna ask them two questions, and we'll just kind of go down the line. How about that? That's a reasonable one. But tell us why you got into vasculitis, and tell us just a little bit about your research. Let's start with the first one first. Why did you get into vasculitis? Divi, you want to start?
Yeah, so I did my medical training in a center focused on autoimmune diseases in general, and my PhD focused on another autoimmune disease called Sjogren's disease. And so when I did my postdoc, so after my PhD, I decided to switch the area, but staying within the autoimmunity world. And that's when I met Dr. Specs at Mayo. And so I worked for 2 years with him in Rochester, Minnesota. And that's where I developed my specific interest on vasculitis and specifically on ANCA.
So you're an ANCA guy. How many people in the room know Dr. Ulrich Specs? He's been around, yeah. So two of these folk, two of you worked with Specs. 3 in the room. Dr. Berthe got to sit down for this one. He's getting a rest. All right, Dr. Yaseen?
So I became interested first in rheumatology, and I was applying for that. And in order to get it, you have to do a little bit of research and work. And I did a little bit of rotationship at Cleveland Clinic downtown, and I started doing research with one of the second-year fellows, and who was working with Dr. Villaforte on a project looking at the recurrent blood clots in GPA patients. And my part was like looking at the chart and like, oh my God, they are super, super sick. Very, very challenging cases. Most of them, they were in ICU, on dialysis, so many blood clots, they were intubated, stroking, and like, I was amazed really like how challenging these cases are. And how the providers that were like taking very good care of these patients. So this is how I started becoming interested in vasculitis. Of course, I started my rheumatology fellowship there, and from the beginning, I'm like, okay, I want to see more vasculitis patients. So I was every day with Dr. Villaforte in her clinic, and even like she doesn't know like I am in the clinic with her. I go in a room and I start interviewing the patient. And then by the end of the first year, like, I really think I really like it. It's challenging, yes. It's overwhelming, could be, but it's very rewarding when you just be with them for 6 months. You make them better, feel better. So, and this is when I decided, okay, I just want to do vasculitis. And I do general rheumatology in addition to vasculitis, but I feel very motivated when I see new vasculitis patient. I feel like this is my area, and I can do the best for this. This is my interest.
Very good, thank you. Dr. Moura?
I think in my case, I think there are 2 points where the interest for vasculitis came about. Very early in my training, I trained in Porto, I'm Portuguese, and I went to Barcelona to do autoimmune disease fellowship. And at that time, I met Maria Sid there, which was my mentor there for the autoimmune disease masters that I actually end up doing there as well. And from that point on, I decided that I was going to dedicate my field of interest or my clinical practice to vasculitis patients, because those patients were fairly complicated, but also very interesting, very challenging, and she actually passed to me her passion. And the other point was then I finished my training, and I started working as a consultant, and I started my PhD. And then obviously I wanted to do my PhD in vasculitis because I wanted to take care of patients with vasculitis. And so then I was fortunate to be in contact with Dr. Spex and to be to apply to the Mayo Clinic and to be admitted. And then Dr. Spex was my supervisor, PhD supervisor, and I worked with him for 6 years now. And I did reach out to a center like Mayo because I wanted to have contact not only with patients, because vasculitis is a rare disease and Mayo Clinic has a lot of patients in comparison to other centers, but also because I wanted to have a very in-depth contact with research, with access to clinical trials and to data and samples from clinical trials in order to develop my thesis and my work. And so from that point, combining those two influences, that's where it sparked to me.
That's awesome. Dr. Bloom?
Yeah, so my journey is a little different in pediatrics. So I'm a pediatric rheumatologist, and we don't really have vasculitis centers. We don't have specialists really in one disease. We're more generally all generalists, but we slowly develop our own interests. And I know that for me, going through my residency and fellowship, and the patients that really stuck out that I gravitated towards were my vasculitis patients for a lot of the reasons that have been mentioned. The disease itself is so complex and interesting, but also the patients are so resilient and go through such a journey, and to do that alongside them is really inspiring. And so I found that I was drawn further to vasculitis as I continued my training. And then also in pediatrics, there's just so little research on it. I think in the adult world, it's obviously a rare disease with not much research, but to me, I'm like, it's so big and there's so much going on. And so in pediatrics, there were just so many questions that, while scary and intimidating, is motivating to pursue that in order to try to make a difference. And so, yeah.
Very good. So it really comes back to the patients, you know? And so I appreciate y'all bringing that up. We'll start over. Ed, what is your research in vasculitis? I'm just kidding. All right, Divi, what is, tell us, explain it. So all of these folks do what I call high science. I don't even get it. And so explain to me what you do. What kind of research do you do in vasculitis?
Yeah, so I'm doing both clinical research, so meaning that I'm running clinical trials at my center in Brest on vasculitis, on the different forms on vasculitis. So we have a quite strong PMR research program and also GCA. And including also AAV, of course. But my main focus personally is what we call translational research, so trying to understand the mechanism of the disease, to try to better understand what happens and what goes wrong when the immune system starts to play it backward and to attack your own body. And specifically, what explains that some of your antibodies recognize part of yourself. So what we call autoantibodies, you know that the ANCAs are antibodies that do not protect you against microbes, but turn against your own blood cells, against the neutrophils. And so the research program I started when I was at Mayo in 2015, so that's already a few years back, is to try to understand among the different white blood cells, so the ones we call B cells. The B cells are responsible for the secretion of immunoglobulins or antibodies. Which ones are the rogue ones? Which one turned wrong and decided to attack, for example, PR3 or MPO in AAV patients? Because the treatments we are using now are effective, but they are also quite risky in terms of immunodepression. That's what we've been discussing a lot the last 2 days. And for example, rituximab works by destroying all the B cells and not only the bad ones. And so our research question is to try to recognize the bad B cells, the ones that turn against PR3, to better understand why they turn rogue, and how we could try to specifically target them to destroy only the bad B cells without touching to the good ones that protect against microbes and make the vaccines work, for example. Yeah. And so this research program was made possible thanks to the VF, because we got a research grant, I think in 2016. So that's some time ago, and I came here in 2017 just to give an overview of what we were planning to do. And so now we are 6 or 7 years later. And so we were able to do it, indeed. So we developed a method to recognize the rogue B cells among normal B cells in patients with GPA. And we've published a few papers about what happens after rituximab, for example. So when we give rituximab, the B cells go away. But when they come back, we wanted to understand why some autoreactive B cells, those bad B cells, come back, and is it associated with the course of the disease? And indeed it is. When we analyze the B cells that come back after rituximab, when the proportion of autoreactive B cells is too high, it announces a relapse. So it could become what we call a biomarker, so something we use to predict relapses, even if it's not doable in real life. For now, it's still research. And the next steps of the project that we are running, so still in collaboration with Mayo and with Alvi Zeberti, who was here on the stage just before, is now to better understand what happens inside the cells. And so what we call the transcriptional profile, so that's the big names for science, but the concept is to try to understand how they use their genes compared to the other B cells, and how we could change that to discover new pathways that are abnormal in autoreactive B cells that could be targeted. And finally, the hope would be to develop what Alvise discussed very briefly, is some cellular therapies that would be, so the CAR T cells, that would be able to target specifically the bad B cells without touching to the good ones. That was a long one.
I told you, it's high science. We'll have to have a good CAR T-cell lecture at the next symposium, I think. You know, it's like a really good topic and kind of the next phase. Dr. Yaseen has already shown some of her expertise this morning. She's a wonderful speaker, lecturer. She's calm as a cucumber, as we would say. Dr. Yaseen, tell us like a little bit more about either your clinical or research passions.
Well, mine are less complex than. So basically, I'm mostly interested in small vessel vasculitis, mostly in IgA vasculitis. This is a very rare small vessel. It may happen in adults, more common in children, but when it occurs in adults, it can be tricky and challenging to treat. And so far, we don't have enough studies and evidence to support any medication or treatment for them so far. And that's my main interest. And I've done a couple of research looking at one very, very common blood pressure medication called hydralazine for hypertension that basically it may trigger ANCA-associated vasculitis. And I think since I started my research in 2018, I think we increased the awareness, and even at Cleveland Clinic, I would say every other month there is one patient gets admitted, and like now nephrology and rheumatology, they are just, okay, look at the medication list and make sure there is no hydralazine. Even the renal pathologist, when she is looking at the biopsy, she goes to the medication list and she listed, okay, patient is on hydralazine, so please make sure that you address it. It could be that. So this is one of my interests. And then the other one, I looked if there is any correlation between patient reported outcome and disease activity index, BVAS score in GPA patient, and that was a very large study. We had almost 300 patients with more than 2,000 visits, and so far there was significant correlation. So physician and the patient, they did agree when their disease was in remission and when the disease was active. So that was also very helpful. And like other thing, but mostly I'm very interested in the hydralazine and in a drug that it may induce some kind of vasculitis.
Yeah, thank you for that.
Mm-hmm.
All right, Dr. Moura, and this is another high scientist. She's a PhD, so buckle up.
So I will try to make it simple. I just finished my PhD. I defended at the end of June, and essentially my research is translational in nature too. Essentially, on the clinical research, I've looked into patients with kidney disease mostly and tried to define what would be the best treatment for patients with severe kidney involvement. I studied how to use kidney pathology scores to better stratify the risk of progression to end-stage kidney disease. And I also studied how to use the MPO-ANCA levels to guide remission maintenance therapy in patients with kidney involvement. Then the other aspect of my research is basic research lab. We were looking into patients with PR3 ANCA patients, and we were trying to understand if the risk of relapse was correlated with the presence of a particular polymorphism. And we actually published recently that there's a polymorphism in patients with PR3 that seems to be related with a higher risk of relapse. And so this goes a little in line with personalized treatment in ANCA-associated vasculitis and try to understand which patients should be treated in which way and which require more of our attention from the beginning. I wanted to say that this kind of work would not be possible without the interaction with several fields, for instance, nephrology and pathology, and also and rheumatology, of course, and also with a very good understanding of the laboratory mechanisms that involve the study, the immune study of patients with ANCA-associated vasculitis. And essentially, this is my research.
Thank you for that. And Dr. Bloom, tell us about your research push.
Yeah, so it's like every other with the high science and the now back to the more simple. So in pediatrics, because there are so many fewer kids with vasculitis, it is a lot harder to do general research studies. And as you may have heard in other talks, kids are not as involved in clinical trials for a lot of ethical and regulatory reasons. And so I'm sort of trying to help the push of playing catch up for the pediatrics and starting out trying to look at databases where we already have information on kids, and can we find the kids within those databases that have vasculitis and look at their past and compare outcomes based on characteristics. Some of the specific projects I've done more recently in this fellowship with Dr. Merkel, I looked at the Vasculitis Clinical Research Consortium data, which is the physician-entered database, and that physicians enter the data. And I looked at patients based on age of diagnosis. And so while the whole database is adults, we divided patients by when they were diagnosed. And there were people diagnosed at less than 18, young adults, middle-aged, and older age, and compared those looking at do they have different disease characteristics based on age of diagnosis, and do they have different outcomes? And so some of the things we found there is looking at children, they end up getting more subglottic stenosis or narrowing of the airway with GPA, MPA, more bleeding in their lungs, and the older population have more neurologic manifestations, so looking at things like that. And we also looked at the damage scores that are used in studies, and so there's something called the Vasculitis Damage Index and the ANCA Vasculitis Index of Damage, and they're used in a lot of clinical trials, but they incorporate factors that the diseases cause, that the medications cause, but also a lot of those may impact older adults more than kids, like maybe the older adult's more likely to get osteoporosis from steroids than the younger child, or diabetes. And so we tried separating out to look at damage that impacts all populations and try and see if we remove certain age-related factors, if that gave us a more identifiable damage score for the kids. And then the last thing is that I'm working with Dr. Merkel to create the pediatric VPPRN. So we've been working with the Vasculitis Foundation and with Christine and trying to transform essentially the same VPPRN that the adults are getting, but making it more understandable to younger patients, and allow for it to ask things about school and development and puberty, and allow kids to enroll themselves. And so pending funding situations, we've been working for a couple of years to get it all situated, so we're hoping to launch that in the future.
Yeah, that's awesome. We'll open it up to questions. You can, write the question, bring it up to Ed, and we'll look at it. There are a couple of cool ones online here that I'm going to ask, and it really gets at the balance of seeing patients and doing your research. And is that a challenge, and how do you balance it? How do you split your time? I'll open it up instead of just picking on someone, but does anybody want to answer that?
I can start.
Yeah, sure.
So I think it's both a challenge and an opportunity, because I see that doing research is really integrated into my clinical practice. So when I diagnose a patient, treat a patient, I try to understand what happens, and if the patient agrees, he will be part of a clinical trial, or he will just agree to be included in the cohort and to give some samples to do the research. And then what we do in the lab just comes back to the patient, and I can try to explain what we discovered. And so it's complementary, I guess. And it's a dynamic balance to find. So it really depends on the stage of your career and what your main focuses are. In my situation, for example, currently I'm spending 1 day and a half a week in the clinics, and the rest is only research in the lab. So I'm very much research focused now, but very likely within 5 or 10 years it will switch back to become more clinical based. It really depends on the organization of your own team and your department, I guess.
Very good. Dr. Yaseen, you have any comments on the balance of seeing patients and doing
I'm
research?
mostly clinical, so I do have clinic every day. And even when I did my vasculitis fellowship, I did only 1 year of clinical fellowship because that's my main interest. But of course, the ideas for research being triggered by seeing patient. For instance, recently I had one GPA patient with digital ischemia, gangrene of the fingers. And I wanted to see the outcome for these patients. It's just like in terms of treatment, and like these, and like I started looking at the medical records, and like so far we got good amount of patients, so I started looking at them. So any idea for research get triggered by seeing patient, and this is how everything starts. I find time to do everything. I try to organize, and I have 2 kids, so it's very hard to organize between your personal life, between your work life, but I think at this point, I'm able to manage.
That's good. Dr. Moura?
So I probably have a different path because in the last 6 years, probably 5 years, I did mainly research with exposure to clinic, but not properly fixed in fixed times. But then when I did the Vasculitis Foundation Fellowship, then I could appreciate what they already mentioned. It's difficult to articulate both times, but you have to be very organized. In the past 6 months, I've seen 200 patients in clinic with vasculitis. So, and then I was able to keep my research work clinical and in the lab. I finished the PhD. So I think I think with some organization you can do that, particularly if you are driven to that. I mean, if you really want to be a clinician or a physician scientist and keep both activities, which I think they are very important because, as said before, I think the clinic triggers questions that we can solve by research, and we can only do research knowing what is important for patients. So having both is actually ideal.
Yeah, that's a good comment.
I don't have too much more to add. I would say that for me personally, I'm in clinic at least 1 day a week, not too much more, but then I do occasional call as well, and then I have a lot of time protected for research, but I'm also very junior faculty and have the opportunity to get protected time to try research and do research, and as long as I continue to get funding, then I can continue on that path of having that balance. And so it's sort of just seeing how the journey takes you, but I think generally speaking, the why is that you do what you do is because of the patients you see in clinic. And so it's really important that even as a researcher, you're getting clinical experience because that's the fun part that gives you the ideas and motivates you to do what you're doing.
Yeah, that's a good point. I fall more on the clinical side as well. That's like I'm in clinic every day of the week and love seeing patients, and that's what I'm good at. And I let you guys do the research. So with that, let's give these VCRC VF fellows a round of applause.